Welcome to Adapting Class, and thank you for deciding to join us. Respiratory concept in the NCLEX is very important, and sometimes prioritization questions can be a little bit challenging. To show you prioritization questions relating to respiratory disorders, of ways the NCLEX will trap you. The nurse is assessing several clients in the emergency department. Which client require immediate intervention? Is it selected apply? So at least one of them may be correct, maybe needed to be intervened. Not all of them. You just pick that, the one you're really, really confident about, right? And as usual, it's a respiratory problem. All of them are airway issues, but not all of them are priority. So be careful. Just because he talks about oxygen doesn't mean he's right. And these are little things, and you get your point and go away. There's some certain conditions you should know that these prioritization is expected finding, and so you have to be sharp when you select the answers. How do you do prioritization? Divide the question into two. Figure out what is the modifier that is being given, right? So this is the first portion of the patient. 55-year-old post-op client. That means a surgery. Okay. And so what? Restless and has oxygen saturation of 85. Do you think this is okay for a patient? And you have to be sharp, right? Breathing issue, electrolyte shock, sepsis, airway, and pain. So what do you think about this patient? 55-year-old, no, 22-year-old asthma patient. That's the first portion of the case. And so what? Just because he has asthma does not mean anything. But what is the modifier? It's diaphoretic and has absent breath sound. Do you think this is normal? Do you think this is expected? Do you think if you know asthma patient is going to be diaphoretic and has absent breath sound? If it's so, then ignore it. A 40-year-old with myasthenia gravis. And so what? Who has new onset inability to speak and have weak cough. Myasthenia gravis patient, inability to speak and weak cough. Is it a good thing? You got to be sharp as usual. 72-year-old with pneumonia who has a temperature of 101.5 and a productive cough. I have pneumonia. I have this temperature and productive cough. Should I be concerned about? A 30-year-old with gunshot wound to the chest who has distended neck vein, muffled heart sound. Buzzwords, muffled heart sound, distended neck vein. In a gunshot wound patient, what do you think? 65-year-old COPD, CO2 of 89, and is drowsy. Do you expect the COPD patient CO2 to be 89 and be drowsy? This is prioritization 101. What do you think? You can put down your answer and we can take a look at it. But what do you think? A 55-year-old who just had surgery and is restless and his height is not 85, probably has pulmonary embolism. This is bad. 22-year-old asthma patient who is diaphoretic, right? Sweaty, is air or anger, and has deep, absent breath sound. Absent breath sound means totally silenced chest. This is a problem. The 40-year-old with the myasthenia gravis who has a new onset inability to speak and weak cough. Most neurological problem, if they can't speak, dysarthria, and speech issue and swallowing problem, that's the airway problem. Pneumonia patient, you have a temperature of 101.5 and productive cough. That's what I know is going to happen when you're in pneumonia. That's not bad. 30-year-old gunshot wound to the chest who has distended neck vein and muffled heart sound. Gunshot with the chest, muffled heart sound, and distended neck vein. This is tamponade. Bad problem. COPD, whose CO2 is 89. He has retained CO2. This is not saturation. That is CO2. So that means it's retaining, it's not exchanging. This can cause a drowsiness, and that's how respiratory distress. So this is the problem. So this is key. So these are questions you may see they will try to trap you, but you have to stay your ground and look for the answers. Try to manage it one by one, and you see you can break it down. A nurse is caring for multiple clients on medical surgical units. Which of the following clients will require immediate intervention? Same thing. 27-year-old with pneumothorax, tracheal deviation to the left. This is a problem and hypotensive. That is what is having tension pneumothorax. 60-year-old with chronic bronchitis, he has productive cough with thick yellow secretion is an expected finding, right? A 45-year-old with Guillain-Barré syndrome who has shallow respiration and is difficult to arouse, this is a problem. And a 70-year-old with heart failure, pink fluid sputum is pulmonary edema. This patient is also in trouble. These are all respiratory example of having issue. 50-year-old post-op with a respiratory rate of 8, pinpoint pupil after hydromorphine. You can see that this is a problem, right? I give you opiate and your respiratory rate is 8 and you have pinpoint pupil, right? I know it's going to drop your respiratory rate, but a respiratory rate of 8, that's not good. So this look like it's overdose. He's having side effects of the opiate that is given. So we should see this patient. If you have tuberculosis and you have night sweats and hemoptysis, this is an expected finding. So don't pick that one. So these are all little things that will trap you. Don't let them trap you, okay? And this is caring for a 4-year-old who's drilling, difficulty speaking, is sitting upright with the neck extended. All of them bad with. What do you think? 4-year-old drilling, difficulty speaking, sitting upright with the neck extended. That's the tripod position. What would you do? This patient has what? The buzzword is drilling, difficulty speaking, sitting upright. This is epiglottitis. If the patient has epiglottitis, are you going to look into their throat and confirm diagnosis? Do you going to draw some culture? Do you use tongue pressures, the pressures and look inside your mouth? Intubate them or start antibiotic. Antibiotic is not a priority. Prepare to intubate for this patient who is in a tripod position. Drilling and difficulty is airway emergency. So that's what you do for this patient. Don't get trapped looking into their mouth, drawing culture and antibiotic. It's not going to help you in this situation. Who should be seen first in an emergency? 45-year-old, history of asthma, is wheezing, right? And he has respiratory rate of 28. Think about it. 60-year-old, chronic bronchitis, a saturation of 90 in room air. 33-year-old, motor vehicle collision has paradoxical chest movement. 75-year-old, a pneumonia, a temperature of 105, 102, and periodic chest pain. If you know the answer, you can put the answer down. But think about this. Let me see what you're thinking. Who in emergency should be your priority? What do you think? Who in emergency should be in your priority? Is this patient asthma who is wheezing and has respiratory rate of 28, or bronchitis patient whose saturation is 90, or patient who has motor vehicle collision with paradoxical contraction and chest movement and a periodic chest pain and a temperature of that? What do you think? Based on this patient, 4 respiratory patients, they all have something going on. Who are you going to see? Asthma patient that is wheezing is expected, right? With the respiratory of it, this is not dying. This is what you expect. Bronchitis is going to have a lot of secretion and is a COPD patient. SAT is not going to be 100. 90 is good. Paradoxical chest movement means you're tired. That is like flat chest, probably multiple rib fractures. This is bad. And pneumonia is going to have pain. So these are all classic symptoms that you're going to see. So this is a bad problem. And this is caring for a client with acute respiratory distress syndrome who is on mechanical ventilator. The high pressure alarm is sounding. What is the next priority? This is a question to test your ability to just relax, go for the buzzword, pick the answers, and then move on, right? I have ARDS and I'm on mechanical ventilator. Those are the buzzwords. Underline the buzzword. ARDS, acute respiratory distress syndrome, and mechanical ventilator. But what is the key? Buzzword is high pressure alarm. I know ARDS is basically you have a stiff lung and you make secretions, and so the lung cannot expand. And so these can block the tube, and so that will put pressure. When you have high pressure alarm, the key word is blockage. So which of these is blockage? That's all. Increased tidal volume is going to worsen the condition. It has nothing to do with high pressure alarm. Suctioning the client, what do you think? Giving them albuterol, what do you think? Checking the tube for disconnection. Once again, high pressure alarm is blockage. Checking for disconnection will give you low pressure alarm. Therefore, this is out. And you left with this. Albuterol can help with bronchoconstriction. That can lead to high pressure alarm. But ARDS has nothing to do with bronchoconstriction. So the content here is thickness and mucus secretion, and that was going to cause blockage, therefore suctioning the patient and the tracheal tube. That is the content here for ARDS to understand what is going on. Who would you see first? I have tracheostomy, I have thick secretion, my respiratory rate of 30. I have tuberculosis, I have nice sweats and productive cough. I have left thoracentesis, okay, and I'm laying on the left side. I have asthma and I'm wheezing, my respiratory rate of 28. What do you think? Who will you see? These are respiratory prioritization content to let you know these are easy to be trapped. This is a question that tests your knowledge. If you have new tracheostomy secretion, it's fine. You're not having any problem. This respiratory of 30 is new, right? Tuberculosis patient is going to have nice sweats and productive cough. Nothing is worrisome here. Left thoracentesis, you damage the lung, okay? You damage the lung on the left side. They should not lay on the left side. They should lay on the right side. Asthma patient should be wheezing. Therefore, this is the right answer. If I damage your lung, I should recover. So I should put it on the other side. These are our trap questions, but if you watch our top NCLEX videos, I talk about all these things so that you don't get trapped. So this is the content related to that. Which client should the nurse assess first? A client post lobectomy with oxygen saturation 94. After remove the lung, they have saturation 94 on 2 liters. Patient who has bronchitis has a bunch of secretion. Patient who has cystic fibrosis has thick secretion and temperature 101. A patient who has tonsillectomy is swallowing frequently and clearing his throat. All are concept-related questions. And I know you know. What do you think? Find the patient if you have 1 second who are going to see. And you have to be sharp and you don't let them trap you, right? Who would you want to see? Somebody is clearing their throat and swallowing after tonsillectomy. Somebody with cystic fibrosis, yes, thick secretion, and then somebody with bronchitis who have like productive cough, yellow sputum, and somebody who have a lobectomy and is 94. A, B, C are how what you expect. This guy is bleeding, so we got to see him first. He's bleeding. Tonsillectomy, clearing your throat, is bleeding. A client with COPD is being weaned from the mechanical ventilator. That means I'm taking off the ventilator. How do you answer questions? Don't just read like that. Just read for the keywords. Underlining, buzzword, I call them COPD, right? I'm being weaned from the ventilator. What is the problem? Which finding make the nurse stopped? That means it's bad immediately. That means something bad is happening. So connect these four information. COPD, weaning. I got to stop immediately. You see, I rewrote the question with these four words instead of these multiple words. I have COPD, I'm being weaned. I stopped immediately because something is wrong. My respiratory rate is 30. I have paradoxical breathing. My saturation is 94 on 40% ventral mass, and the end-tidal CO2 is 45. What do you think? A lot of traps there, but go with the content. I try to highlight it to you. We winning, that means something bad is happening. Which of this is bad? And if you have 1 second, who will you see? Right? That's the question. Who? Respiratory rate of 30 is not bad, right? Patient is being warned is going to be anxious, right? Paradoxical breathing, it means you're tired. You're going to have respiratory failure. Ventral mass 92, that is the precise amount of oxygen. It's a COPD patient, it's fine. And end-tidal CO2 is 45, so it's not retaining. Therefore, this is your right answer. Paradoxical contraction of breathing is bad. It means that diaphragmatic fatigue and individual will have failure. And this is caring for post-surgical client who suddenly develop sharp chest pain, dyspnea, and hemoptysis. Which provider order should the nurse implement? Go for the buzzword. Chest pain, shortness of breath, sputum with some blood in it. What are you going to do? It's a post-op patient. Think about it. First, ask yourself what is going on with the patient. What are your buzzwords? Post-op, sudden onset of chest pain, dyspnea, and hemoptysis. What are you going to do? What are you going to do? What are you going to do? Start heparin infusion or give them oxygen or get a CT of the chest or D-dimer. Anybody who had surgery and is having acute onset of chest pain, dyspnea, and hemoptysis, that's pulmonary embolism. Therefore, pulmonary embolism, which of this is most important? Hypoxia. Give them oxygen. Heparin is not going to solve it. Later on, we give him heparin. CT scan is just looking for more studies. ABG is still looking for more studies. Heparin is going to treat the problem, but it takes a while. Give them oxygen. These are respiratory prioritization. They're a little bit difficult, so be careful. Which finding require immediate intervention? And that is caring for a client with chest tube. I have a chest tube. Know things about chest tube. They are content related. Continuous bubbling in water seal. Drainage of 75 bright red in first 4 hours. Presence of tidling in the water seal chamber. Client report mild pain at the insertion site. So which of this is need immediate intervention? Continuous bubbling of water seal chamber, 75 bright red blood in the tube as soon as you place it, or presence of tidling in the water seal chamber, or client with mild pain at the insertion site. What do you think? These are content related chest tube. If you need help, I have a bunch of video on chest tubes. You can watch them for free. But water seal, you can have bubbling there, but if there's bubbling, it should be intermittent. I don't need any bubbling there, but if it's going to be bubbling, it should be intermittent. 150 and 275 bright red blood when you insect it is okay. Up to 200 is worrisome. Tidally means the chest tube is working up and down, up and down. And the client with mild chest tube insection pain is fine. But this is okay. 75 bright red blood. Don't pick it. It's as soon as the first hour, it's okay. This is bad. What should the nurse do first? This is the same question we did. And nurse is caring for a post-op client, sudden onset of dyspnea, tachycardia, pruritic chest pain. We have a PE. If I have a PE, what is my priority? I already told you. Respiratory support. Give them oxygen, give them oxygen, give them oxygen, give them oxygen before you do anything. IV fluid is going to worsen the situation. D-dimer, yes, you check D-dimers. D-dimers are checked to see if there's a cloud, a fibrin cloud product. Of course, you're going to notify the provider, but this does not need any orders from the provider. Always pick an order answer choice that does not need orders. Place the patient in high flow and give them oxygen. It's not going to require orders from the provider. Therefore, that's the best answer. If you knew this is adapting, Chris, thank you for watching. As we left with two questions, if you want more, you can subscribe to the channel, share, and then share it with some friends, and join our membership. You get restricted videos, or you can join our crash course at www.adaptingclassreview.com. You see a crash course, and then you can or you can email me and we can talk about it. The next is working with the license LPN and UAP. Which task should the nurse assign to a LPN? Assess a client who is reporting shortness of breath. Administer albuterol via nebulizer. Teach a client how to use incentive spirometer. Evaluate a client response to a diuretic response. This is management of care associated with the respiratory. What do you think? LPN, what will you give it? Which assignment will be appropriate for the LPN? You know, LPN does not do assessment, so this is gone. LPN does not provide any teaching. They can reinforce the teaching. LPN does not evaluate the response of this requires some form of assessment. They can give medication without any problem. And the last question, for patient, who do you want to see? A pneumonia without temperature and coughing yellow sputum. Albuterol, he has saturation of 91 after asthma patient with saturation of 91 after albuterol. Patient has anaphylaxis and he has stridor and a weak pulse. COPD saturation of 88. Once again, don't get trapped. Last questions. Good luck. What do you think? Based on what we talk, you see, it's the same theme, keep on coming back and forth, right? Pneumonia, I know you're going to have fever, you're going to have sputum. Just ignore it, right? Asthma patient, your saturation is not going to be perfect, but this patient is not using accessory muscle, it's not doing anything. Don't worry about it. Anaphylaxis with the stridor, weak pulse means shock. And a COPD saturation 88 on oxygen, there's no evidence of respiratory distress. This is your right answer. Thank you for watching. And once again, this is adapting class. Just a little bit, few questions to get you. I try to use questions to show you content. So to that, like you have to be able to get the content and then apply it. But there's certain things about content you have to know. When it comes to respiratory questions, they are most of them are prioritization. So watch for traps. You have to know expected finding, and then they won't trap you. Which one you should worry about? And this is what the questions are based on. If you like this video, you can join adapting classes on demand. And good luck in your exams.